Okay, let's unpack this. You've shared these pretty dense revision notes, haven't you? Full of critical info about a medical condition. It's rare, but wow, vital to spot quickly.
Absolutely. And turning notes like these into something, clear and memorable, that's the real challenge, especially for revision.
Totally agree. So today, that's what we're doing. We're taking these notes you've shared and doing a deep dive into neuroleptic malignant syndrome, NMS.
Right.
Our goal really is to cut through the detail, pull out the absolute must-know stuff, and help build a kind of mental map from these pages that actually sticks with you.
Like turning that text into something you can actually use under pressure.
Exactly. Okay, let's get into it.
Let's do it. So starting right at the top, what is neuroleptic malignant syndrome? Basically, the notes describe it as a rare but potentially life-threatening reaction.
And those notes, they really zero in on the key features, don't they? What are the sort of pillars we should be looking for?
Yeah, there are four main ones. They're kind of the foundation. You've got severe muscle rigidity, hyperthermia, that's a really high body temperature,
Right.
then altered mental status, and autonomic dysfunction.
Autonomic dysfunction.
Right.
So that's things like heart rate, blood pressure, sweating, all going a bit wonky.
Precisely.
Yeah.
Yeah, the body's automatic controls are off kilter. Picture someone like really stiff, burning up, confused, and their vitals are all over the place.
Okay. That combination, that's the immediate flag for thinking NMS.
That's your starting point.
Mm-hmm.
And a really crucial bit these notes highlight is who's at risk. Now, obviously, patients taking antipsychotics are the main group,
Mm-hmm.
but importantly, can also happen in patients on dopaminergic drugs, things like levodopa for Parkinson's.
Oh, that is a key point, not just antipsychotic.
Exactly. And here's where it gets, quite interesting and maybe a bit counterintuitive.
Mm-hmm.
The notes stress it's not just about starting these meds or upping the dose.
Mm-hmm.
It can actually happen if the drug is stopped suddenly or if the dose is cut right back.
Wow. So withdrawal can trigger it too. That feels like something you absolutely have to remember if you're managing these medications.
It really is. And, well, the reason it needs spotting fast is the mortality rate mentioned, up to 10%. That kind of underlines how serious this is.
Yeah, definitely. Okay, so we know what it is, roughly who gets it, why does it happen.
Yeah.
The notes talk about the etiology, the cause.
Right. And the main takeaway, as the notes say, is that the exact why isn't fully nailed down. But there's a really strong link to an abnormal sort of idiosyncratic response to dopamine-blocking meds, mainly antipsychotics.
So something about how these drugs mess with the brain's dopamine system?
That's the main idea, yeah. The notes talk about complex things like dopamine dysregulation in the central nervous system, which then seems to throw off the body's control centers. Temperature control is a big one.
Okay. And following from that, the notes list specific risk factors. So beyond just being on the drug, who is more likely to develop NMS?
Well, there are a few things that seem to increase the risk. High-potency antipsychotics get mentioned.
Yeah.
Rapid dose increases too. Or using high doses or those depot injections. Those are kind of medication factors.
What about the person themselves? Are some people just more vulnerable?
Yeah, seems so.
Hmm.
Younger age, being male, dehydration that comes up a few times, having other medical problems, or importantly, having had NMS before.
Right.
And looping back to that point we just made, the withdrawal of anti-Parkinsonian medication is specifically listed here as a risk factor as well.
And dehydration again. You mentioned environmental factors like high temperature. That link feels really significant.
It does seem crucial, yeah. Dehydration and heat. Also, if the patient is very agitated or catatonic, that's noted as increasing risk too.
Okay. And are there other drugs, besides the usual antipsychotics, that these notes mention can cause NMS?
Yeah, this is useful. The list is broader. Less commonly, things like prochlorperazine, for nausea, promethazine too. Certain atypical antipsychotics like clozapine, risperidone, even some anticholinergic drugs, metoclopramide and lithium, are on the list as potential, though less common, triggers.
That's a really important reminder. Got to check the full medication list, not just the antipsychotics.
Definitely.
Okay, let's touch briefly on the pathophysiology. How does this dopamine blockade actually cause those symptoms?
Well, the simplified version, based on the notes, is that blocking dopamine receptors, especially in brain areas that control movement and temperature, well, it reduces dopamine activity. And this drop in dopamine is thought to directly lead to the muscle rigidity, mess up the body's thermostat, and disrupt those autonomic nervous system controls.
And the muscle damage. That gets mentioned too.
Yes, that rigidity can be so intense it actually causes muscle breakdown. That's rhabdomyolysis, There's also a hypothesis mentioned linking the dopamine block to glutamate release, which might add to neurotoxicity and muscle damage. A bit complex, but the core is dopamine blockade.
Right.
Okay, now for the really practical bit, the differential diagnosis. You see those core features: rigidity, fever, confusion, unstable vitals. What else could it be? The notes really stress this part.
Yeah, this section is basically your essential mental checklist. You have to rule out the lookalikes. The list includes simpler things, like an acute dystonic reaction or akathisia, but the notes give a great clue. Those usually respond quickly to anticholinergic drugs. If they get better fast with that, probably not NMS.
That's a fantastic clinical pearl right there. Simple reaction gets better. NMS likely won't, not from that. What are the other big mimics?
Serotonin syndrome is a huge one.
Yep.
Lots of overlap in symptoms like altered mental state, autonomic changes, but different causes, different management. Malignant hyperpyrexia, the reaction to anesthetics, that's another one.
And what about things like overdoses or just getting too hot?
Absolutely. Recreational drugs, cocaine, amphetamines, they're on the list. And importantly, different types of heat illness. The notes specifically call out phenothiazine-related heat stroke.
And give a key difference. Typically, no rigidity and absent sweating. So if the person's hot but floppy and dry, you're thinking maybe more along the lines of heat stroke, not classic NMS.
That's a great distinction. Stiff and maybe sweaty versus floppy and dry. Super useful.
Exactly. Other possibilities listed include lethal catatonia, organophosphate poisoning, plain old heat stroke, infections like encephalitis, think HSV, rabies, hyperthermic reactions to MAOIs, muscle issues like polymyositis, or just rhabdo itself.
Wow, quite a list.
Yeah, and other drug toxicities too, like from anticholinergics or SSRIs. It's broad, which is why having those core NMS features clear in your mind and knowing a few key differences is so vital.
It sounds like a classic exam question setup, doesn't it? Here are the symptoms, what else could it be? And NMS is always a contender. How common is it, though, really?
The notes say rare. Occurs in, a small percentage of people on antipsychotics. Specific UK data is apparently a bit limited. But importantly, it can hit anyone on the triggering drug, doesn't matter about age or gender.
So rare, but doesn't discriminate once you're exposed. What does it actually look like at the bedside? The clinical presentation part brings us back to those key signs.
Right back to severe muscle rigidity, hyperthermia, altered mental state, autonomic dysfunction. The notes highlight typical signs. Fever, that marked rigidity, agitation, fast heart rate, tachycardia. Less commonly, maybe breathing issues, tremors, other weird movements.
And when does it usually kick off? Is there a usual time frame?
Generally, yeah. Often within the first few days or weeks of starting or increasing the drug. The notes often cite the first 10 days. But crucially, like we said, it can happen later. Or, don't forget, when reducing or stopping the drug.
So you can't relax just because someone's been on a drug for ages. The notes also give a specific checklist for diagnosis, don't they? Like formal criteria.
They do, yeah. It gives a bit more structure. You need exposure to a neuroleptic in the last 1 to 4 weeks, hyperthermia, a temp over 38 degrees C, and muscle rigidity.
Okay, those 3.
Plus, you need at least 5 other features from a specific list in the notes.
Okay, what's on that +5 list?
That includes altered mental status, tachycardia, unstable blood pressure, high or low, tremor, incontinence, sweating or salivating more, elevated CK or myoglobin in the urine, that's the muscle breakdown evidence of metabolic acidosis, or a high white cell count.
Right.
And the final, absolutely critical bit is ruling out other medical or neurological causes. So that checklist from the notes is how you formally nail down the diagnosis.
That's really helpful for remembering. Drug plus temp plus rigidity plus 5 from the list and rule out other stuff. Okay, so what tests do we run to back this up and exclude those mimics?
Well, the notes are clear. Diagnosis is mainly clinical, based on signs and symptoms. The labs and imaging are there to support it, gauge how bad it is, and help rule out things on that differential list.
So what key lab findings should we look out for based on these notes?
Okay, so a full blood count might show a high white cell count leukocytosis. U&Es and blood gases check for electrolyte problems or acidosis. Interestingly, low calcium often pops up. Liver function tests might show raised enzymes, often from the muscle damage.
And that really key muscle damage marker.
Creatine kinase. CK levels. The notes stress these are usually significantly elevated in NMS because of the rhabdomyolysis. You should also specifically check urine myoglobin. Coagulation studies are important too, looking for DIC, that clotting problem mentioned as a complication. And of course, a urine drug screen is vital, checking for sulcolates, cocaine, amphetamines, helps with ruling things out.
Right. Labs confirm the damage, rule out mimics. What about scans?
Imaging. Chest x-ray if you're worried about infection. A head CT is pretty crucial if mental status is altered to rule out brain issues, and maybe a lumbar puncture, a spinal tap, to exclude things like encephalitis, especially with fever and confusion. The notes mention the CSF protein is often high in NMS itself.
That's a pretty comprehensive workup described there. Okay, so you've made the diagnosis. How do you treat NMS according to these notes?
The absolute first thing, immediate, non-negotiable, highlighted everywhere.
Yeah.
Stop the drug, discontinue the causative antipsychotic or dopaminergic medication.
Step 1, stop the trigger. Then what?
Then it's all about aggressive supportive care. You need to monitor vitals constantly, actively cool them down, push IV fluids to protect the kidneys from the muscle breakdown products, and use muscle relaxants or benzos to control the stiffness and agitation. Severe cases. Straight to hospital, likely ICU.
Are there specific drugs mentioned to actually treat the NMS itself?
Yeah, the notes mention specific things that might be used. Dantrolene, it's a muscle relaxant, often considered. Bromocriptine, which is a dopamine agonist, is also listed as an option sometimes, presumably trying to counteract the dopamine block.
Okay. And other practical things.
Airway protection is vital if they're really out of it or rigid. 4D-benzodiazepines are generally preferred for agitation rather than, physically restraining someone. Cooling blankets, ice packs for the fever. If the rhabdo is bad and kidneys are struggling, maybe urine alkalinization or even dialysis.
Right.
And interestingly, the notes also list ECT electroconvulsive therapy as a potential option if meds and support aren't enough.
That's a really thorough approach outlined. Immediate actions, support, specific drugs, even advanced options. What's the prognosis? What's the outlook for someone who gets NMS?
Generally, the notes say it's favorable if, and it's a big if, it's recognized early and managed properly. Stopping the drug and good supportive care usually means symptoms resolve over days to weeks.
But there are still serious risks involved.
Oh, absolutely. Even with good care, severe cases can lead to major complications. Things like kidney failure, DIC, cardiovascular collapse are mentioned. The mortality rate, while better than it used to be, is still significant. The notes quote ranges like 5 to 11.6%.
And what are the main things that can lead to death or long-term problems?
The causes of death specifically noted are cardiovascular collapse, respiratory failure, and acute kidney injury. Long-term issues can stem from respiratory failure, seizures, or kidney damage. The notes also point out that older age, breathing problems during the illness, and how high the fever gets are linked to worse outcomes.
Really underscores the need to manage that temperature and breathing support aggressively. The notes also list the complications explicitly, reinforcing how bad they can be.
Yeah, it's a serious list. Kidney failure from rhabdo, respiratory failure, heart rhythm problems, DIC, seizures, cardiac arrest, lung inflammation, pneumonitis, blood clots like PE. It affects multiple systems, so you need to watch for everything.
Okay, nearly there. Wrapping up the main content, how can we try and prevent NMS?
Awareness. That's the absolute key, according to these notes. Just having a high index of suspicion. Thinking about NMS in any patient on these meds who develop suggestive symptoms, especially after dose changes.
So really watching closely after starting, changing, or even stopping these drugs.
Exactly. Vigilance around those transition points. And the notes also frame early diagnosis and stopping the drug as prevention, preventing it from getting worse, preventing those severe complications.
Makes sense.
And finally, patient education is mentioned. Telling patients and families about it, what to look for, encouraging them to report symptoms quickly.
Yeah, empowering the patient seems crucial.
It really is.
Okay, let's try and connect the dots here. Pull out some high-yield memory aids from all this detail.
Right. The absolute core thing to remember is those 4 main features: rigidity, altered mental state, autonomic dysfunction, hyperthermia, maybe think RMDH, or that fever mnemonic is pretty good. Fever, encephalopathy, altered mental state, vitals unstable, autonomic, elevated CK enzymes, rigidity.
Yeah, fever's good. It includes the CK level, which is so central to the investigation. So you see those fever signs, especially with the right drug history, you think NMS.
Instantly. And then think about the flow we discussed from the notes. Drug exposure leads to those fever symptoms. Symptoms trigger test, especially checking that CK level. That's your big clue about the muscle damage.
And management is stop the drug first, cool them down, fluids, support everything, watch for complications.
Exactly. And when you're faced with someone who's rigid and hot, run through that differential list quickly. NMS, serotonin syndrome, malignant hyperpyrexia, heat stroke. Remember those key differences the notes pointed out, like rigidity might be absent in some heat stroke, or the anesthetic link for MH, or different drug triggers for serotonin syndrome? Just knowing one or two sharp distinctions can really help narrow it down.
So why does this matter to you, the listener? Because as these notes clearly show, even though NMS is rare, missing it or delaying treatment can be catastrophic. But catch it early, stop the drug, give support, the notes say the outcome is usually good.
Right.
It's a perfect example of how spotting a specific pattern quickly can save a life. And going through detailed notes like this, piece by piece, helps build that pattern recognition, makes you better prepared.
Yeah, it takes it from just words on a page to something you can actually apply.
So we walked through these revision notes covering the definition, causes, risks, pathophysiology, what NMS looks like, investigations, management, prognosis, complications, the whole picture.
Hopefully, breaking it down like this, pulling at those key points and memory hooks, makes this really complex topic a bit more digestible, whether it's for your exams or just for your clinical awareness.
Absolutely. And maybe a final thought to leave you with. Think about that daily tightrope clinician's walk using vital meds like antipsychotics while staying alert for rare but severe reactions like NMS. What does that constant need for vigilance and for clear patient communication really tell us about the art and science of medicine?
It shows the notes are the guide, but it's the clinician's awareness and interaction that makes the difference.
Well said. If you are tackling complex topics like this for revision and found this deep dive approach useful, you might want to check out resources at passthemsra.com and freemsra.com.
Yeah, definitely worth a look. Best of luck with your studies and practice.
And that was our deep dive into neuroleptic malignant syndrome.